Okay, so I'm going to be talking about cardiac MRI for assessment of myocardial viability. Now, there are two ways to assess myocardial viability on a cardiac MRI. You can either do a late gadolinium enhancement, which tells you the extent of necrosis and residual myocardium that can be revascularized, or you can use a low-dose dobutamine stress CMR, which will tell us of the ability of dysfunctional segments to regain wall motion and normality with dobutamine. Now, beginning with the CMR protocols, the first thing is that who do we do a LGE CMR in, which is late gadolinium enhancement. So we would like to do it in patients who have confirmed coronary artery disease with some degree of regional myocardial dysfunction and who are being considered for revascularization. The other group would be in whom we would like to do a dobutamine stress CMR to assess the reversibility or the gain of function. And we can also combine the two, that is the low dose dobutamine CMR along with the gadolinium enhancement. We would consider patients' contraindications to gadolinium-based contrast agents such as renal dysfunction or allergic reactions. And for patients who are on beta blockers or heart rate lowering calcium channel blockers, we would get a blunted response with dobutamine. So we would like to stop those before the test begins. The imaging protocol is usually begins with cine images followed by late gadolinium enhancement and dobutamine stress CMR. Excuse me, and we'll be coming to this in a little more detail later on. Now, in terms of analysis of myocardial viability by CMR, I'd like to explore two different areas, and then I would want to connect them so that there is a deeper understanding of how we do late gadolinium enhancement. So the two areas are tissue injury and gadolinium kinetics. So when the patient develops some myocardial injury, there's tissue necrosis with escape of the contents into the extracellular space, and there's expansion of the extracellular volume. And of course, that also instigates an inflammatory reaction, which results in a positive cascade. Now let's move on to the second part, which is the gadolinium-based contrast agent kinetics. So once a gadolinium-based contrast agent is injected, it essentially strays intravascular. There is a wash-in period and there's a very rapid washout. So if I were to say that in a normal patient, once the gadolinium is injected, it stays intravascular and is excreted as such because the cell membranes are intact. If the cell membranes are ruptured, it gains access to the cell and the gadolinium molecules would rest inside the cells and they would show up on a scan. And if there is a scar tissue, that also indicates that there is a disruption of the cell barrier and there's an expansion of the of the extracellular space, and the gadolinium would rest there. And once we image, that would lead to enhanced myocardium being visualized. So how do we do this? The first thing we do is we do cine studies, and after the cine studies, as I mentioned already, we do the late gadolinium imaging. Now, late gadolinium imaging would mean that this would be done somewhere between 10 to 20 minutes, and we can add a dobutamine stress CMR. So we inject a gadolinium-based contrast agent, we wait for 10 to 20 minutes, and then we start acquiring the images. Now, essentially, the principle is that you make the entire myocardium black so that the scar myocardium becomes enhanced by gadolinium and the gadolinium starts to shine up. So all that glitters is not gold in cardiac MRI. So that's the golden rule. And how do we do this? So we apply a 180-degree magnetic pulse and remove all signal from the myocardium, which means that the magnetization becomes horizontal. We then wait for the signal to recover, and you will see that the signal will slowly come back up. And this is something that we call T1 relaxation. Now, T1 relaxation takes a very small duration of time, and that time is known as the T1 time. So essentially, we knock out the signal in the normal myocardium. And how do we do this? So we apply a 180-degree pulse here and remove all signal from the normal myocardium. Then we wait. We wait for this duration of time, which is known as Ti, so that the normal myocardium becomes completely black. Now, if you look at the top, there is an oval bubble that says gadolinium reduces T1 time, which means that when you start to take the image, what we see is this. Normal myocardium is black, but the high gadolinium causes the infarcted myocardium to recover earlier, which means that there is a high tissue contrast between normal and scarred myocardium. So what have I said so far? The gadolinium-based contrast will not enter the normal myocardium. It will reduce T1 time. If you apply a 180-degree pulse, it will make the myocardium, normal myocardium black. And the difference between recovery times generates contrasts between the two kinds of tissue. Scarred myocardium is white, bright, or gadolinium enhanced, and normal myocardium is black. How do we interpret this? So if there is no gadolinium enhancement, that means that there is no scar. If there is gadolinium enhancement, then scar is present, and we then assess the percentage of transmurality, which means what percentage of the transmural diameter of the myocardium is actually enhanced. So these are the four broad categories at 25% break-offs, and we'll go into this a bit deeper now. Excuse me. So I hope the cine is running and everybody can see this. Is that all right? Okay, so I'll take that as a yes. So in this three-chamber view, cine view, you can clearly see that there is a marked hypokinesia of the anteroseptum, and there is also akinesia of the apex, and we can also see this black area here, which is a deep dark shadow. Now let's look at the gadolinium enhanced images. Now the area marked in green is black. This is normal myocardium. And the area marked in red is bright, and this is scarred myocardium. So this is the difference, how we say that this is viable or this is non-viable. I've also marked out another blue area within the cardiac apex. This is a thrombus which has not taken up the contrast. Now, let's look at this image from the same patient. So this is a transverse section, short axis, sorry. Now, within the green areas are the normal myocardium, which are black. And then you see the red areas that are marked with red, which are highlighted or which are gadolinium enhancing. So these are the scarred areas. Now, in terms of transmurality, if you look at the area in the septum, it is absolutely 100% transmural, at least in the infroseptum. Some viable tissue in the midseptum, but the anteroseptum is non-viable 100%. However, if you look at the anterolateral wall, you can see that there is some myocardium that is still preserved on the epicardial side, indicating that the subendocardium to the mid-endocardium, which is in the range of about 50 to 75%, is non-viable. Now, this is another case, and you can see here that the anterior wall in the two-chamber view and the apex is severely hyperkinetic or akinetic with a reduction in LV function. If you look at the areas marked in red, they are all highlighted or they are gadolinium enhancing, which means that the entire LAD territory is almost completely transmurally scarred. If, however, you look at the inferior wall, it is still dark black or the signal is very low. A short axis view from the same patient shows that the anterior territory or the LAD territory is scarred to variable extents, but the other territories are dark. But why is this important? This is important because the degree of transmurality actually tells us about the possibility of recovery of myocardial function if we revascularize this patient. Now, the data shows that if the transmurality is more than 50%, it predicts poor recovery of LV function. But patients who have less than 50% of gadolinium enhancement in terms of transmurality can expect improvement of LV function after revascularization. Now, moving on to dobutamine stress CMR. In dobutamine stress CMR, what we do is a low dose infusion of 5 to 10 micros per kilo body weight per minute, and we gradually escalate that to 30 to 40 microgram per kilo body weight. Now, in an ischemic myocardium, there is a normal baseline function, and when you give them low dose dobutamine, the function gets better, and then as you go high on the dobutamine, the function goes down again. If you have viable myocardium, then sometimes you can have a sustained response, which means that although the baseline function is depressed, low dose dobutamine causes a better response or improvement in LV function, followed by further improvement if there is if there is a high dose infusion. And then there is a classic biphasic response in hibernating myocardium where low dose dobutamine infusion causes an increase followed by a decrease in myocardial function if there is a high dose dobutamine infusion. And of course, then there is the non-viable myocardium which doesn't show any change at all. Now, there are certain limitations to dobutamine stress CMR. Firstly, that this is a visually graded and binary evaluation of wall motion scores. An improvement of one grade of myocardial contractility would denote an improvement in function. And of course, this would call into question the reproducibility of DSCMR. And the other thing is that there are significant differences between viability on late gadolinium enhancement and contractile response, and this is primarily due to cellular changes and tethering changes that really are not picked up on both of these modalities. So the summary so far is that late gadolinium enhancement picks up fibrosis, predicts recovery, 50% is the cutoff, and if you combine the two, it improves the accuracy. If we look at this data, we see that the dobutamine echo has a high sensitivity, and similarly, the late gadolinium enhancing CMR has a higher
2 minute
sensitivity
reminder.
but a lower specificity. And the dobutamine CMR has a higher specificity with a positive predictive value. So the way to go forward about these is you combine the two, and that gives you a better result in terms of predictability. I don't think I'll have enough time to go into end diastolic wall thickness and the cutoff of 5.5%, but we do know that 20% of dysfunctional and thin myocardial segments do have limited scar burden. If we look here, the scatter is quite wide and the correlation is minus 0.22, which means scarring in thin myocardium is really not a very good predictor of whether the myocardium will recover any function. And again, if we look at the middle panel, we can see that those who have less than 50% scarring still get slightly better LV function at follow-up after revascularization, while those with more than 50% myocardial scarring do not get that much of an improvement between pre and post-procedure follow-up studies. Same thing here again.
Yes, we can.
And these are some of the newer methods, and where we talk about quantification of segmental contractile function with feature tracking or myocardial tagging, but this is still in the research phase, and you can use MR spectroscopy for assessment of phosphate metabolism, something on the lines of PET scanning, but again, that's simply in the research phase. Thank you.